Welcome back to part 16 of our IPDRG Explainer series on Decode Healthcare with Harshal. I am absolutely thrilled to have you here today. In our last session, we wrapped up part 15, looking at inpatient obstetrics and delivery outcomes. Well, today, we're flipping the script and shifting our focus to the baby. We're going to break down complex inpatient neonatology clinical documentation, simplify those ICD-10-CM Chapter 16 guidelines, and see exactly how they drive your MSDRG grouping. But before we jump in, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Your support is what keeps this massive 150-part series completely free for medical coders everywhere. Here's a quick look at our syllabus for today. We'll kick things off with Chapter 16 rules, dive into the Z38 birth status code, talk about prematurity and birth weight, review common neonatal conditions, and then tie it all together with the MDC-15 DRG impact. Okay, Section 1, Welcome and Chapter 16 Rules. So ICD-10-CM strictly defines the perinatal period as the time frame from before birth through the first 28 days following birth. But here's a really important caveat you need to remember. If a condition originates right here in this perinatal window, say a congenital condition or a specific birth trauma, it can actually be coded throughout the patient's entire life if that condition persists. It's not just restricted to the first month of life if the clinical implications require ongoing monitoring or treatment. This brings us to the absolute golden rule of Chapter 16. These codes, running from P00 to P96, are assigned only on newborn records. You literally never mix these up and place newborn codes on the mother's clinical documentation. The mother has her own set of obstetric codes, the baby has their own chart, and that is exactly where your P codes belong. Mixing them up, that's going to absolutely result in claim denials and grouper errors for sure.
Moving right along, Section 2, Z38 Birth Status Code.
You absolutely must assign a code from category Z38 as the principal diagnosis on the initial birth record of every single newborn baby. For example, Z38.00 tells us we have a single live-born infant delivered vaginally in the hospital, while Z38.01 indicates a delivery via C-section. Putting this code first immediately tells the DRG grouper exactly what kind of admission we're looking at. It's the foundation of the whole claim. Now you're going to master this rule. A Z38 code is an event code used exclusively for that initial admission. It is never ever reported on readmissions. Think of it like a birth announcement, right? You only announce the birth once. If that baby goes home and gets readmitted a week later for jaundice, you do not use the Z38 code again. You would sequence the jaundice as your principal diagnosis for that next encounter.
Let's dive into Section 3, Prematurity and Birth Weight.
When our tiny patients arrive early, physicians will often document both their birth weight and their gestational age in weeks. And when you have both, birth weight always takes sequencing priority over gestational age on the medical record. Why is that? Well, from a resource perspective, a severely low birth weight drives the intensity of hospital care way more than the gestational age alone. Some of these incredible infants weigh under 1,000 grams, which, to put into perspective, is about the size of a standard block of butter. So sequence your P07 code for birth weight first, followed by the P07 code for gestational age. Okay, here's a fantastic pro tip, straight from official coding clinic guidance. ICD-10-CM actually does not provide a code for preterm infants past 36 completed weeks. So, if you have an infant born at 37 weeks or later, and the provider documents late preterm infant, you absolutely cannot just force a prematurity code on the chart, no matter how tempting it might be. Instead, you must query the physician. Ask them if the newborn should be classified as small for dates or light for dates. Getting that precise documentation is the lifeblood of the IPDRG system.
Next up, Section 4, Common Neonatal Conditions.
You are going to constantly encounter these conditions on inpatient NICU charts. We're talking respiratory issues like transient tachypnea of the newborn or TTN and acute respiratory distress syndrome. You'll see metabolic issues like neonatal jaundice, maternal exposure to group B strep, and infant of a diabetic mother, which usually means keeping a very close eye out for hypoglycemia. You'll also see congenital heart defects like atrial or ventricular septal defects. Having a really strong command of this clinical vocabulary is an absolute game changer for accurate inpatient coding.
We can often spot missing specificity just by looking closely at the clinical indicators. If you're reading a delivery record and you see indicators like apnea, bluish skin, breathing problems, or limpness at birth, your brain should immediately jump to meconium staining or meconium aspiration syndrome. If you see those indicators but there's no formal diagnosis documented, That is a prime opportunity to shoot a concurrent query over to your Clinical Documentation Integrity, or CDI team. We have to make sure the documentation accurately captures the patient's true severity of illness.
And hey, do not forget your present on admission, or POA rules here. This is huge for hospital quality metrics. Congenital conditions automatically receive a POA indicator of 1 because they are completely exempt from standard Y or N reporting. By definition, they are present at birth. Getting this flag right ensures your hospital isn't unfairly penalized for hospital-acquired conditions.
Let's look at the financial side of things in Section 5, MDC 15 DRG Impact.
So, newborn cases group into MDC 15, which covers newborns and other neonates with conditions originating in perinatal period. The MSGRJ grouper logic follows these exact steps. Step 1, it checks for that Z38 principal diagnosis. Step 2, it looks heavily at birth weight brackets, like under 1,000 grams versus over 2,500 grams. Step 3, it scans for significant operating room procedures or mechanical ventilation. All of these factors combined figure out the final DRG and the relative weight, which directly drives the hospital's reimbursement.
But watch out for this critical nuance right here. Keep a very close eye on the discharge disposition. If you transfer a newborn to another acute care facility, or if the infant tragically expires, it completely flips the final MSDRG logic and relative weight. You absolutely must validate that discharge status against the medical record before you finalize your claim, because it literally changes the entire grouping logic.
All right, bringing it home with Section 6, Summary and Next Lesson.
We covered a ton of ground today, from the absolute necessity of the Z38 birth status code to strict sequencing rules for birth weight versus gestational age, and how those factors directly drive the MDC 15 grouping. But are you ready for Part 17? Next time, we are pivoting. We're jumping into an introduction to ICD-10 PCS, breaking down that 7-character alphanumeric structure. You are not going to want to miss how we map operative reports to those specific 7 characters.
If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Your dedication to mastering this material is exactly what makes you such an invaluable asset in the revenue cycle. As you pull up your very next chart, ask yourself, are you just keying in numbers, or are you truly capturing the clinical story of this newborn's critical first days of life? Keep practicing those sequencing rules, and I'll see you in Part 17.